ourselves, gives us a little bit about our background, just so you know where we've come from to get where we are. As much as anything, Pete and I are very different from that point of view as well, it should be said. I guess I'll start from that and then I'll hand over to Pete. Pete has more background than I do in this area. So I'm Dr. Ross Pollock. I'm co-director of our MSc postgraduate diploma in Aerospace Medicine, along with Pete Hodkinson. I'll hold my hands up at the very start. I'm not a medic. I've not studied medicine. It is not top of my list of things to do. I'm a physiologist. And that's where all my background has come from. So I'm very much an aerospace physiologist, not an aerospace medic. Pete, on the other hand, is a medic. But I initially studied at an undergraduate level sport and exercise science, briefly did an MSc before doing a PhD and a lot of postdoctoral research, mostly looking at aging and exercise and muscle. So nothing to do with aerospace medicine whatsoever, but very much applied physiology and how your body responds to exercise or slightly more extreme environments in some cases, but again, mostly from an aging perspective and understanding healthy aging. After I finished up some of my postdoctoral research, I ended up in 2015 going to work for a company called Kinetic in the UK, who are an engineering company for the most part, who do a lot of work for the Ministry of Defence in the UK, amongst other things as well, but that's probably one of their biggest income streams. But in that engineering company, they did have a flight physiology and an applied physiology group, and they ran, at the time, the UK's only human carrying centrifuge, which they essentially owned and operated on behalf of the military for the most part. And they ended up doing a lot of centrifuge research and trying to understand how people respond to high G environments and how we can protect people in that. But on top of that, did a little bit of hyperbaric physiology, because they did have hyperbaric chambers with thermal chambers. So we touched on all of that, mostly from the aircrew perspective and what it means for military aircrew. Although, like I said, I did dabble in other bits of that as well. And the one other topic I would have touched on there was musculoskeletal injury. And again, this is mostly neck pain in pilots who have to wear fairly heavy helmets and do a lot of things when they're pulling G, or even in the back of a helicopter. So that was my background in aerospace medicine from the 3 or 4 years I worked there. Following that, I moved over back into King's, back into academia to help lead the aerospace medicine courses that we run here. Initially with David Gradwell, Professor David Gradwell, who retired last year, at which point Pete came in. And that's what we've been doing in the last few years. And what probably is worth just quickly saying, the academic life, I'm assuming it's the same in the States, is yes, you're responsible for teaching and education and running courses, but a big part of what we do is also research. So we are expected to, and actually at the bigger universities, probably predominantly expected to do research. So from that point of view, I will still do the kind of aerospace centrifuge-based research, also the aging research. So I've been quite lucky to kind of go those two branches. But that's how I ended up doing aerospace medicine, a very roundabout way, completely unplanned. It's dumb luck I ended up where I am, and this is how I've come to be here. But I'm very fortunate because I can do multiple things that I enjoy, because I still like the aging exercise stuff, but I also like doing things in the centrifuge and the aerospace medicine side of things as well. So I can combine them both quite luckily in the same job. That's my quick background. Pete is a little bit different. I'll hand over him to tell you what that is.
Thanks, Ross. Hi, Pete Hodkinson. So I guess slightly differently, I've been working really hard to plan to try and get to this position for like 20 years. So not by chance at all. It's a bit like you guys trying to pick off the different bits along the way to see what's possible. I guess growing up, I liked, well, I would have loved to have been an astronaut, but I also liked the idea of being a pilot. And then my parents persuaded me I should get a degree first, and I quite liked science in general, as well as the idea of helping people. And so that science and helping people bit naturally kind of comes together, as I'm sure for some of you, into medicine. In the UK, you can do it slightly differently. So from high school at 18, I went straight into medical school at Edinburgh. So you start straight into, and that's the kind of normal way. Medicine for most people would be their first degree, as opposed to doing it as a graduate entry. It's only in the last 10 years or so, probably, we've started to introduce more of the graduate medicine courses. And I think there's a lot of strength to having that diversity of experience before you go into medicine. It does clearly delay things a little bit, but in the US, from my understanding, your training scheme postgrad's shorter than ours anyway, so it all kind of balances out a bit. While I was at university, I really liked how the human body works or doesn't work, particularly in extreme environments. So that started to bring me back to expedition, wilderness, and then into aviation and thinking about space, going back to those kind of childhood dream bits, but bringing it into the medical world. And I found the Human and Applied Physiology Masters at King's. And the advert said, do you want to be spun in a human carrying centrifuge and decompressed in an altitude chamber to 25,000 feet and learn about human physiology in the extremes? And I was like, yes, that sounds great, and go and do diving with the Royal Navy and stuff. So that was my first exposure to King's then. So I took another year out of med school at Edinburgh and went down. And they ran that course back then alongside the course that I now run with Ross, the postgraduate diploma in aerospace medicine. So I got exposed to aviation medicine in the military at that point. And in the UK, it doesn't get mentioned at any point in a normal medical school curriculum. So had I not done that course, I would never have even known that this was a possibility to do it. Off the back of that, I applied to the Royal Air Force, got sponsored as a medical cadet through the rest of university, and then was effectively on a kind of stream to try and do some form of aviation medicine, as it was in the UK. The UK government was very anti anything to do with human space flight at that point. So it was an aviation focus, although personally there was always the space element to it. Went through normal university after that. Royal Air Force medical officer training and normal officer training. Spent a year on a station up at RAF Kinloss looking after aircrew flying the Nimrod, wide body aircraft maritime reconnaissance. But also did some research down at the RAF Centre of Aviation Medicine, looking at the backup oxygen delivery system for the F-35 Lightning and doing some altitude chamber research with that. So kind of, again, just hooking back in at various stages of the career, different projects that I could. And then following normal hospital jobs for a couple of years, got into aviation and space medicine, specialty registrar training or equivalent of kind of residency. And by that time, they were looking to the future somewhat, and they'd added space into the training curriculum. So it was a nice chance for me to guinea pig the proposed training curriculum and try out some of the space element training. So I got to go over to European Space Agency for some bits, but also got to spend some time with the US Air Force up at Beale Air Force Base, looking at the U-2 and the full pressure suit operations for high altitude reconnaissance aircraft. And in amongst those bits, also doing clinical work with the Civil Aviation Authority, aircrew medicals, and getting that kind of breadth of the specialty in the field. And did a PhD at Cambridge looking at the prevention of hypoxia in helicopter aircrew. And so that was then, which might be of interest to some of your members, blurring the boundaries between the physiology and medicine and the engineering. And I'll talk a bit more about that a bit later, but that's a particular interest of mine. And then other bits, I've done some incident and accident investigation training and courses as well, and worked at the RAF Centre of Aviation Medicine as a consultant for 4 years after residency training, and then joined Ross at King's to carry on with a slightly different focus and try and pivot from mainly aviation and a bit of space to mainly space and a bit of aviation is what I'm hoping I'm going to be able to develop. Although clearly reality in the UK and the funding and support for that is slightly challenging to do those bits. And met Ross through various bits from the RAF role. And I was a medical officer in charge of the G training on the human carrying centrifuge for 10 years in the RAF. So that's where I got to know Ross pretty well as some other projects that we'll talk a little bit about in our talks, I think. And that's probably enough about me and Ross. Get happy to take any questions or interruptions related to that, or hand back over to Ross, and I think he'll give you a few slides to talk through King's and the courses.
Yeah, absolutely. So that was a great introduction for the both of you. It's great to kind of understand how you both approach the same point from different aspects. So it kind of shows the diversity that's available to approach the same point in the field. So yeah, we can get right into understanding more about the program and the structure of the program, what it aims to accomplish, and how an overseas student, or I guess an international student, would be able to come over and take part of the program. That'd be fantastic.
Okay, so I'm going to share a screen if that's okay. This wants to work. Hopefully you can now see a nice picture of London, possibly Tower Bridge.
Yes.
Good. It's a good start. Okay, just hopefully that what Pete and I were saying about where we came from highlights that there's many ways into aerospace medicine. I'm reluctant to say medicine because I'm clearly not a medic, but aerospace physiology or aerospace engineering, they all branch over and cross into many fields. Another thing to note as well is that the space side of things is really an extension of the aviation side of things. Most of what we know from space came from aviation initially, and actually it's just applying it to a higher altitude with different gravities to some extent, but a lot of this overlaps, which is kind of the principles in which we run the course. But the course that we run, and there's one thing that I actually probably should address just based on some of the emails that we had with you there, is that you talk about residency programs. This isn't a residency program. UK doesn't work like that. It's very different. So this is just purely an open access course that anybody who's got a medical degree can apply for. So as long as you're a medic, you could just apply for our course. You could sit the course in either 6 months or a year. You come out with a degree at the end of it. The residency type of things, we don't quite do that. People talk a little bit about something called the specialist registrar, which is a little bit closer to that, which is something which our course feeds into, but that is not what it is. It is just a one-year course that, in theory, anyone can do who's a medic. We do have other courses that run in the department, which I'll mention as we go along, which cover some of the same fields, but people who aren't medics can apply for as well. So our course, let me just make sure I'm on the right screen here. You'll probably hear me, as much as anything, flip-flopping between saying the Diploma in Aviation Medicine and the Aerospace Medicine program. We talk about these as the same thing. Actually, they're not. The Diploma in Aviation Medicine is actually just a couple of exams which people sit at the end of our course, which technically we don't administer or nothing to do with, but our program very much leads to you being able to pass those exams, and that's the qualification you're given. It's the historic part of our course. So the Diploma in Aviation Medicine is a course which has been running for about 53 years, and it started at Royal Air Force Institute of Aviation Medicine, which is based over in Farnborough. So that was very much a military organisation running that. And then in the late 90s, that organisation broke up and became the Centre of Aviation Medicine in the military. And then there were some private companies formed from that. At that point, Air Vice Marshal John Ernsting, soon to be Professor John Ernsting after that, he was in the military. He left at that point, and then came to King's and brought the course to King's. So it was only about 20 years ago that the course, in the way that it's formed, came to the university, and we started running it here. It was never actually degree awarding for the first 15 years at the university. So you just came, did all these classes, and then go and sat an external exam, which is why I got the Diploma in Aviation Medicine. About 4 or 5 years ago, we made it a credit-bearing course within the university. So if you complete the course, you get a King's Award, either as a postgraduate diploma or an MSc. You would then also go and sit the Diploma in Aviation Medicine exam, and then you get a Diploma in Aviation Medicine. So you get 2 awards for doing this course, assuming you pass all the appropriate exams, of course. So it's a bit confusing from that point of view, and it means it's just got a very checkered history. I will quickly say a few bits about King's and where we fit within King's, because it just gives you a bit of context about where we are in the grand scheme of things. So King's is fourth oldest university in England. It's quite a large one. We have about 30,000 students here, about a third of which are postgraduate students, so MScs, PhD students, that type of thing. And we're kind of ranked within top 10 in the UK, and I think 31st in the world in terms of university rankings. And as most big universities, they really pride themselves on the research that they do, and that's where a lot of our prestige and ranking comes from. And in the UK, they do rank universities for that as well, and we're kind of up around 6 for that. King's is a multi-campus university. It's all based in central London, which is what you can see here. Actually, has River Thames. You've got London Bridges somewhere down here, Houses of Parliament, Queen's House is over here, pretty much. We are based on our Guy's campus, which is affiliated with Guy's Hospital, which is why we're here, and that's just over next to London Bridge and Tower Bridge. So those pictures you saw on the first screen, that's pretty much where we are. But we do have campuses at St Thomas's Hospital. We have a campus at Waterloo next to the Millennium Eye. And then we have a campus in the Strand, and then others at various hospitals around London. So Denmark Hill and King's College Hospital is down south of the river. So most of our campuses are kind of affiliated with a hospital of some description. And unfortunately, because of the nature of where we are, they're probably 3 of the busiest hospitals in the UK at the moment who are bursting at the seams with COVID patients, because we are very much central London hospitals in dealing with a large case load of that. We are located in the Faculty of Life Science and Medicine, which is one of the biggest and largest research centres in Europe for health sciences, essentially. it gets very complex in terms of how we are broken down into different research and different schools, and then we've got different divisions within all of that. What matters is we've probably got about 60 programs of study, a couple thousand staff for actually only about 5,000 students. So we do have quite a high staff student ratio, which is great. As I said, we're very much located at places reflecting the work we do with the NHS and the health services in the UK. And we're aligned with something called King's Health Partners, which is where we bring academics and clinicians together to the hospital, or from the hospital, and we just try and get them working in groups to try and really change education and clinical practice where they can, and doing research in those areas. And it's very much translational research, so we do a lot of kind of bench to bedside type of things in the university as a whole. Not necessarily what we, myself and Pete, do, but as a wider grouping, we do that. Where our course really sits and what matters. So we're in the Faculty of Life Sciences and Medicine. That's part of the academic department of Physiology, which is the kind of teaching side of things. What Pete and I really associate with is the Centre for Human and Applied Physiological Sciences. It was previously the Centre for Human and Aerospace Physiological Sciences, but we had a name change a year or two ago. There's only about 15 members of staff in this group, but as a division, we probably punch above our weight in the university. We do quite a lot of research in a very applied setting. So we're relatively small, but do a lot. And we run 3 courses. The one that obviously we're talking about mostly today is our Aerospace Medicine, MSc and Postgraduate Diploma. But we do also run a Human and Applied Physiology MSc, and it's worth mentioning at this point, up until last year, we did run a Space Physiology and Health MSc as well. Unfortunately, that program closed as part of a wider restructuring of the university. But what we were able to do was take the best bits of our Space Physiology and Health program and incorporate them into our Human and Applied Physiology MSc. So the Human and Applied course actually would take people who aren't medics, so it's just open to anyone who's got an undergraduate degree, so any of you could apply for it without having done medicine. We do get medics doing that course. We have a lot of people who are, we call them intercalating medics. So if you're doing a 5-year medical degree here, you can sometimes take a year out and just do another area of study. That's what Pete did during his. So it's not uncommon for that. But the Human and Applied course, it covers some very detailed cardiovascular, respiratory, muscle physiology to start with, but then in the second semester it really turns into more extreme environments, aerospace physiology, and it takes all the best things from the space physiology and health course and some of the kind of interesting stuff from our course as well, and does that. So that is a good option if people are interested in that type of area, if they're not medics. If you're a medic, our course is really where you want to be for the aerospace side of things. We do also run a BSc, so an undergraduate program in sport, exercise and medical sciences, but that's not what you're here to hear about. That's a slightly different background, so don't worry about that one. Our department, and as I said already, is very much related to the research we do and what we end up doing. We've got 4 main research teams. Because we've got such a small grouping of academics, so there's about 15 of us, a lot of us cross multiple groupings. So actually, I think I dabble in each of these because of my background. I'm quite a varied person. You don't get many that are as spread as I am. It's the way it's gone. But we have a muscle form and function group who are very much interested in things like basic muscle physiology, so looking at satellite cell function within the muscles, cardiac stem cells, all the way up to the applied physiology side of things, looking at master athletes and how their muscles adapt, which is something that I did. We've got a movement, function and behavior group, which is more interesting in human movement in relation to things like Parkinson's disease, people with vestibular problems and developing vestibular rehabilitation and training programs. We've got respiratory physiology and medicine group, and again, very much looking at clinical respiratory conditions, but also developing different respiratory techniques and methods to assess that. And they do obviously have links with our aerospace physiology and medicine group, which is what I'll talk a little bit more about now in a touch more detail. So this group, the main members of it would be Tom Smith, who's the kind of lead of the group, who isn't with us today, myself and Pete, but we do have a number of other individuals here who kind of dabble in this area as well. Some of them are visiting positions now. So Thais, for example, she was a full academic member of staff up until last year, at which point she left King's, but she still has a visiting position with us. But our aerospace physiology and medicine group, we do lots of varied research. So, for example, we've done things where we've developed a skin suit or helped develop a skin suit which has been flown in the ISS. So it's a counter pressure suit that astronauts can wear to help try and counteract some of the issues that they have in space. So we have done a lot of work in combination with ESA, looking at that. We've also done a lot of work looking at CPR in space. Oh, wrong slide, wrong button. In addition, this is Dr. Julie Keeble up here, who holds the delightful record of probably being the person with the most experiments flown in the ISS, which is quite a claim to fame. That's partly because one of the things that we do here is we run a summer program for school children, so 12 to 14, 15-year-olds, to come and do, it's called Mission Discovery. So they come here for a week. It's a residential thing. We have some astronauts come in and help run the week with us, and it's just all about getting them interested in space and doing things related to that. But what they do as part of that is they create, we split them into about 30 different groups. They all come up with an experiment that they could fly in ISS. At the end of the week, we decide which one was the best experiment, and that experiment gets flown in the ISS. So it's a great program for school kids to be involved with, because they get experiments flown in the ISS, and there's not many school kids that can probably say that. Julie's very instrumental in running that, which is why she has done so much in relation to that. But it's really good because we do get astronauts regularly come over and chatting for that, and on some of our courses as well. We've quite a large interest in acceleration physiology, or certainly I do. That's really where my background is in the aerospace medicine side of things. This is the old centrifuge, as it were. That was the one that I worked on, which is now closed because we've built a newer and better one that the RAF run. But I've done a lot of research on that, looking at things like acceleration atelectasis, which is collapse of the lung under G, depending on what oxygen concentrations you're breathing. Looking at how anti-G suits, G trousers, can protect people, and the physiological changes associated with them, how different breathing gases can influence your response as well. We're clearly very closely linked with the Royal Air Force and the Centre of Aviation Medicine in particular, which we'll probably touch on again in a moment. Tom Smith is not here, and myself and Pete, actually, we've all done this. We're very interested in the effects of gravity on the lung, and also suborbital space flight. So we know that things like SpaceX, and all of these new companies coming out, Virgin Galactic, and they're going to start just putting people like us with more money in space, essentially. But what does that mean in terms of, we're going to suddenly put all these probably rich but probably unhealthy people into space? How are they going to handle the accelerations that is required to get them there and back? Because they do have some quite dramatic acceleration profiles, interspersed with some microgravity. So Tom is very interested in doing that research, and we should have some studies coming up. We have done one, and hopefully some more coming up in the next year on the new centrifuge to look at how the acceleration profiles you'd experience during that launch and re-entry, as it were, influence the body. We've also done work looking at space analogues. So muscle loss in space is clearly a very big issue, and this is we developed a hyper buoyancy flotation thing to help identify bed rest. So it's a sort of hypersaline is what I should say. So you lie in this bed filled with water, but saline rich water, so you should float on it a bit more than a normal bed. I've had people on that for a week or two and just looked at how much their muscles waste away over that short period, which obviously is very similar to what happens to astronauts to some extent when they go to space. We do a lot of hypoxia related research. Pete has clearly done that in the past. And we do also some slightly more detailed things, and a couple of members of our group have done work with, I don't know, last year there was, you may have been aware that the Nobel Prize in Physiology and Medicine went to a group, one of which was Peter Radcliffe, who very much interested in looking at HIF, so hypoxic inducible factor. Our group were involved with some of that research. Sadly, not the ones to get the Nobel Prize. They didn't have that big a contribution, but they have published with them and done that type of stuff. So coming down to the very cellular side of things. And also one of the things that we're quite involved with is this textbook. So Ernst's Aviation and Space Medicine, which is pretty much seminal textbook. I think there's two big textbooks in this field. There's this one, and then in the US they probably read Fundamentals of Aerospace Medicine a little bit more, but certainly UK and rest of the world outside of Europe probably default to this one quite a lot, which was initially written by John Ernst, hence the name, but is edited by David Gradwell, who was our predecessor. And we're just about to go through an iteration of this to the next edition, which we'll all be contributing to. That's a very quick whistle-stop tour of some of the research we do. There's a lot more than that, to be very honest, but that's just kind of some of the big things, just to give you a flavour of that. In terms of our actual course, I've already mentioned there's a diploma in aviation medicine and our aerospace medicine course. Technically not the same thing, but they very much overlap. Diploma in aviation medicine is actually just a couple of exams that you sit, which are run by the Faculty of Occupational Medicine. So this is very much the medical side of the UK things. But our course is the only course that's recognised as the preparation for that exam. So if you had to do a course to do that exam, this is it. So everything we do is geared towards you sitting and passing that exam. And all those exams run in March. And the only thing I would ever say with this is we don't assess the DipAvMed, we assess our own course, but they all end up being the same. And we still have all the people involved with the DipAvMed lecturing on our course, and we speak to the examiner so we know that everything's lined up properly. So it's just one of these slight intricacies. It's a kind of confusing field because of that. The course itself is taught by a mixture of people from King's, so myself, Pete, Tom Smith, who I've mentioned, predominantly a couple of other individuals. We have a lot of input from the Centre of Aviation Medicine, which is a branch of the Royal Air Force. So we do have a lot of military aviation specialists teaching in the course and other external organisations, which I'll come back to in a little bit. How the course runs is the first semester, so September to Christmas essentially, is taught in the Guy's campus on London. The second semester, which is January to March when they have their exams, is taught out of the Centre of Aviation Medicine up at RAF Henlow, so it's actually based up in an RAF base a little bit north of London. And throughout, we do lots of trips to different external organisations or other military bases to really make sure people get a full understanding and practical experience of AvMed. And I'll talk about those things in a moment as well. The course itself is a level 7 course, which is a postgraduate course in the UK. We run our courses in a slightly different way to you would have in the States. So you work under credit hour ratings, I think, a lot of the time. Each of our courses, you need to achieve a certain number of credits to be given an award. So for the Aerospace Medicine course, if you're doing the MSc route, you need 180 credits. If you're doing the PG Dip route, you need 120 credits. You attain these credits by sitting the modules we have in our course. So for the PG Dip, there's 3 modules which are each worth 40 credits. You have no option of what you do, you just have to do them, there's nothing else. So you can't substitute different things to get that. It is just, there's 3 modules, which we'll talk about in a moment, that you sit, and if you pass, you'll have a PG Dip. Those doing the MSc will then do a 60 credit research project module, which is basically you go and do some research in the summer and write it up at the end. The modules we have, the first main one is our Aerospace Physiology module, and as the name suggests, it talks about aerospace physiology, and it's really where we try and get people to have an understanding of how the aviation and space environments influences the body and the implications of that, and also looking at some of the strategies and protection measures that we have to prevent the adverse effects of these environments having too much influence on you. And this, we focus very much on altitudes, decompression, obviously very relevant, acceleration, again, mostly from a fast jet perspective, but we do also talk about what you might get in terms of space flight and suborbital space. We'll then go into microgravity, go into thermal stress, spatial disorientation, very relevant in the aviation environment and space environment, and then cover noise and hearing. So that's the main topics that we would touch on in there. The other modules we do are our operational aerospace medicine module, which is really designed to help people get a bit of an understanding of what factors influence the operation of an aircraft from the crew perspective. So this isn't an engineering module, it really is how do the crew interact with the aircraft. So what we go into here is the aeromedical considerations for designing a cockpit. A big problem we have with most aircraft, whether that's a spaceship or just a fast jet that's been developed here, is that all the engineers go off and they develop this plane and they forget that somebody needs to sit in it. So it's really about trying to figure out how does that person interact with that environment they're in, and that's what this module really comes onto. So that's our kind of ergonomics and equipment integration. So how do you interact with that environment? How does your equipment help you interact with the environment? We do a lot of human factors and crew resource management. So how do people interact within that environment? So if you've got multiple people in a crew, there has to be some way that they interact and work together. We cover that. We look at the sources of errors and accidents. Sadly, they do happen. We hear of plane crashes a bit more commonly, it seems, in the last couple of years than we have recently. But looking into the background of that. Then just other things like aircrew selection, sleep fatigue, and again, another important one's ejection and crash from aircraft. Again, very much from a military context quite often, but we do a lot of work around that from other aspects as well. The final module that everybody would do is our clinical and commercial aerospace medicine, and this is really where it comes to trying to understand how diseases or conditions people have would be impacted by the aviation environment. It's all very well being here on ground doing nothing, but if you have somebody with a condition and take them up in the air, to some extent, how is that going to influence it? A lot of that is just focused around all the main clinical conditions. I'm not going to sit here and list them all, so we'll do cardiology, respiratory, endocrinology, everything you can think of. We'll get specialists come in and talk just in each of these areas and how they're influenced by aviation specifically, or space specifically. We'll look at transport of the sick and injured, so aeromedical evacuation is very important, as is aviation pathology. Sadly, if something does go wrong and someone to pass away, whether that's a crash or even in the air, we will cover that. Psychiatry and psychology, again, is becoming very big. There has been some notable incidents in the last few years where people have purposefully crashed airplanes. So the psychiatry or the psychiatric issues behind that are very interesting. And then we also do cover some of the regulatory side of things. In the UK, we have the Civil Aviation Authority, which cover all that. The equivalent in the States would be the FAA. So we just touch on some of the things that they would cover. So that's the top components. There's a lot of theory. It is quite an intense course for getting all of that information on board. We keep them busy for 6 months and give them a lot of lectures, and then they get their exams at the end, but hopefully they get there. For those then going on to do the MSc, they'll go and do a research project. So this is in the summer. You'll go and do a project in aerospace physiology or medicine somewhere. This can be lab-based. Most of the time it is lab-based. Sometimes we'll do clinical ones, which might be more looking at, what's an example? We had somebody who did it at British Airways and looked through their medical records, looked at diversions, tried to understand what were the implications of diverting an aircraft because of different medical incidents. So that's more of a kind of clinical paper-based research. The majority do more hands-on lab-based practicals. And these are conducted either here at King's, where we can simulate different altitudes with our hypoxic tent. We're doing some work looking at how the angles of ejection seats and weights in the chest might influence your work of breathing. We can do thermal trials here, so we do a lot in-house. We do also have some people working or being shipped out to go and do things with the RAF on the centrifuge. So I have a PhD student at the moment who's doing a centrifuge study, and some of our MSc students will do a project kind of embedded within that. But we've also had people go to the European Space Agency, the Austrian Space Forum in the past, a couple of places in Japan and France who've also done aerospace medicine related research. So we do look for opportunities out with of our own little bubble where we can, and we do have a lot of collaborations and contacts that can allow us to do that. In terms of the places that we send people in the course off to, what really makes our course stand apart from most of the others is the practical experience. You're taught by the experts in the field, so essentially all the people who wrote the books, as it were, or the chapters in the book, but also we send them out to go and see these places. So our students will go to the European Space Agency for 3 days. So we ship them all over to Cologne in Germany, and they go to the European Astronaut Centre out there. They get to meet some astronauts. They have a lot of talks and lectures from the people within ESA that are responsible for certain areas of their space program, as it were. But the good thing about being there as well is they have their own, they've got ISS mock-ups that you can go and have a look around in. They've got a very deep pool that you can, well, we don't put our students in it, but it's where the astronauts would do a lot of their underwater training. They've got a short arm centrifuge, so we can actually go and see all the facilities they have and how they would use it and how it interacts with their astronaut training side of things. The students will also go to Martin Baker, which is a company that develops ejection seats, so they'll be able to really see and understand how ejection seats are developed. Again, very much fast jet focused. They'll go to the Civil Aviation Authority to look at things more from a regulatory perspective. A couple of days there. One of the highlights is always the trip to British Airways medical services they get. So it's a 4-day trip. A lot of it's lecture based, but they then do go and get to play in the BA simulators, so they can go and pretend that they're flying. Successfully or not, it's a 747, something like that. Quite often it's probably crashing a 747, but they try. They get to go and down one of the emergency slides out of some of these larger aircraft, which you would never get the opportunity to normally, so they really enjoy that kind of thing. They go to the Air Accident Investigation Branch, so any air crash that there is, the remains of the plane are always taken to the AAIB, so they can actually go and look at some of those wreckages, sadly, but then get a lot of the theory and content around that. This is the new centrifuge we have in the UK, which the RAF run. So we'll go and we'll spin our students on that. We'll take them up to 7G, get them wearing some anti-G trousers so they can really experience what proper G feels like, not the little bits that you may have experienced in the past. It's a very nice machine, this one. It's even got an integrated flight simulator, so you can fly it. So it's a great experience for the students. Take them to NATS, which is an air traffic control centre that kind of governs all of air traffic control in the UK. So they can see how air traffic control works, which is actually very important from the aviation side of things and the medical aspects associated with that. I keep calling this sea survival. It's not really, it's warm water, but it's warm swimming pool survival. But we go and give them the experience of what you would need if you were immersed in water, life rafts, life jackets, and how to do that. We will do a land survival session as well. So we take them down to the hills a bit south of London for a day and get them wandering through the woods to see how they can handle that. And then we do a lot of trips to different operational military bases. So they'll go to an army base where they learn a lot about rotary wings, so helicopters, and the medical implications of using them and the issues they have. They'll go to a Navy station and get the Navy perspective, so it's not just Air Force. They'll go and see, in the UK we've got something called AvMed Flight, so the Centre of Aviation Medicine has a couple of planes which are dedicated to do the medical research side of things. So they'll go to that base and look at the types of stuff they do. In addition to having practicals on night vision goggle training, spatial disorientation training, pressure breathing, thermal practicals, hypoxia practicals, we tend to do all these types of things with them as well. So it's a very hands-on course, and we give them a lot of experience in terms of visits and just the practical aspect of things. And as I said, I mean, a lot of this is really focused on the aviation side of things, but all of this just extends on up into the space. A lot of this stuff is what you would get astronauts doing anyway, because this is the analogues that they use. So the context is always there, and we try and highlight that throughout the course as well. That is my probably a bit longer than it should have been brief of the course. Sorry. I'll probably stop there. If you've got any questions, I'm happy to take them, but Pete will probably say a few things more about the medical training side of things and a couple of other bits here, but I don't know if any of you have got any questions at the moment.
No questions from my end, but just a comment. That was amazing to hear about. So thank you for delving into detail for that, because that was epic.
Yeah, sorry, it was a bit much. You've got the full view of the course. Who knows? Someday you might get the pleasure of doing it if you want.
Perfect. Thank you.
Yeah, you got on a roll, Ross.
Sorry.
Now, just to check the timing, I think we were meant to talk until for about another 7 minutes or so, and then to leave kind of 10-15 minutes for questions. Is that about right?
That is accurate. We can extend that 7-minute time frame just a bit more. We make it like 10 or even 15 minutes if needed. But yeah, what you said is the current plan. Yes.
Yeah.
Okay.
I don't know about you, but I've got nothing immediately pressing after this. At 3 o'clock, I've got another meeting here, so I have no idea what time it is where you are. If it overruns, it's not a problem, is what I'm trying to say. So it's not an issue from that point.
Great, fantastic. Yeah, I think we'll spend maybe another. Let's go for like maybe another 10 minutes or so on Ross's presentation, and then we can spend some time. We just got just a few questions, I think.
Yeah.
We can go through those.
Yeah, great. I'll just share my screen to run through a few slides. I won't go through all of them, I don't think, in terms of time, but there's a few bits that I'll illustrate with them. Now, hopefully you can see the first slide there, showing just Spartan Aerospace Medicine talk, and you can still hear me okay.
Yep, all good.
Yep.
Great. I'm just going to go through a few bits to build on what Ross has talked about in terms of where the courses fit into the equivalent of residency in the UK, and then I'll expand a little bit more around the specialty and the kind of research that we've done, building on what Ross has talked about. I talked through most of my background here. One of the bits that I wanted to just go on is on the sort of right-hand side of the screen. In terms of the different organisations. So clearly arranging this talk is great, because one of the key bits is finding out that the specialty or the field exists, and then it's getting to talk to people to find out about how you get involved, and then pestering people to let you have a chance to do something related to it. So these are some of the organisations I've been involved with over the years that are great ways to go. And in the States, clearly ASMA, the Aerospace Medical Association, would be one that I would direct you to if you're not already part of they've got their Aerospace Medicine student and resident organisation, AMSRO, that's really great. So it was just networking, mentoring, really important, try and get into the field. And then the other bit I wanted to talk about in terms of background is the fun stuff that you hopefully get to do if you go into the field. And I enjoy doing these things, but for me, it's also really important you get to understand the culture and the language and your patient populations of interest by getting out there and doing these activities with them. So if you've either got a clinical consultation or a project where you're looking at life support, whatever for these, you can talk to the operators and understand a little bit of insight into their working and operating environment a bit better by having experienced some of it for yourself. So I would encourage you both, because these things are fun, but also because it helps the job. Definitely, that's the sales pitch for work, to go out and do some of these things as well. So in terms of the specialty in the UK, aerospace medicine in the US clearly has been established for a long time. In the UK, we had a small group that could train in aviation medicine, but only in the Royal Air Force, going back to the 50s and 60s. Well, I mean, they had the lab during World War II, but the specialty training really in the RAF was post World War II. And that continued through, but it was a very niche area. And then they had a big review of medical systems in the UK in the late 90s, and they killed all specialties that weren't part of the National Health Service. So it disappeared for a little bit, and then in the early 2000s they realised they still needed it, so they started to work to recognise the specialty again, and they recruited me in the RAF in 2009, saying it would be sorted in a year or two. And then I finished my training in 2015, and it still hadn't been recognised. But they got it there in 2016, and the General Medical Council approved it as a specialty. So people can formally train in aviation and space medicine now, which they hadn't previously been able to do. So that is great. Clearly, space gets all the interest, but most of the residency is aviation focused. This hopefully is going to give you an overview of UK medical training. So starting with medical school, like I said at the start, it's a 5-year course undergrad normally, or you can do it as a 4-year course as a graduate student, a bit more like you'll be familiar with in the US system. You come out of medical school and then you do these 2 foundation years. So this is kind of junior doctor training in hospitals. And then you would go through a selection process at this point to what they call core training. And then you've got another 2 or 3 years where you'll do general medicine in the hospital, which is what I did, or acute care, acute medicine, or anaesthetics, critical care training, or general practice training, which is kind of family physician training. So you've got 4 or 5 years post-medical school in the UK, and you end up having to get some membership of a Royal College or fellowship of different ones. Oh, that's a mistake. That this is in the curriculum actually, but that should be MRCGP. You don't need to be a fellow of that. Anyway, you have 4 or 5 years postgraduate, and then you apply in the UK to go into what would be residency training, which over here is called specialty registrar training. And let's see, can we block in that? Yeah, no, nothing there. So it's 4 years minimum residency. At the moment in the UK, you can only do aviation and space medicine with the Royal Air Force or with the Civil Aviation Authority. So it's quite constrained. We're hoping there will be more opportunities. I'm hoping that's one of the things I'll be able to develop at King's, would be to get the funding and model to be able to have people to go through training and residency with us. But it's not like the US, where you can potentially pay to do some of the residency programs, from my understanding. It really is a kind of on-the-job training in the UK, and then you pop out as a specialist at that point. So it is a little different. And the bit Ross was talking about in terms of our course at King's and the Faculty of Op Med Diploma exam, that then is just a component of your 4-year or more residency program.
It's worth mentioning at this point, I'm going to interrupt you, Pete, so somebody should say it if you're not going to. Just to give you an idea of how new all this is and the fact that there is scope for it to change, Pete is currently the first and only aviation and space medicine specialist trained registrar, as it were. There's a few more would probably like to follow soon, but that's how new it is, and Pete is currently the only one.
This is true. Hopefully there'll be more soon. Now, in the interest of time, I won't spend very long on these, but I just wanted to, depending how much you've had as a group about what aerospace medicine is all about, it is managing risk and it is preventing injury, illness, deaths, incidents, accidents, whether that's on the clinical side or on the research side that Ross was talking about. So this was a aircraft that didn't pressurize properly. The aircrew lost consciousness due to hypoxia, crashed, killed all of the passengers on board. This is the kind of thing that we want to try and prevent. This Red Arrows are the UK high performance display fast jet team. Lost one of those in almost a decade ago now due to the effect of G-forces. So even the most highly trained people can succumb to things that we've known about for over a century. People have medical problems on board. When that's the pilot, mid-flight, not such a flight safety critical issue, but it might still require them to divert. If this happened during final approach, it could have a direct flight safety implication. So trying to use the physiology and medical knowledge of the specialty to improve flight safety is one of the key bits. And likewise, you get involved in incident and accident investigation potentially when things don't go so well. So there's great diversity within the specialty that you could get involved in. And as indicated by our course being run by a physiologist and a doctor, it takes lots of different perspectives. You could easily have a psychologist or an engineer as part of our team running the course as well, because there are so many different aspects that you need to draw into the specialty in our courses. So I would say it is a big team sport, and that's one of the things that I really enjoy and like about it, is the diversity of opportunity and things that you can get involved in. You can be much more clinical and be looking at the cardiovascular fitness standards or assessments of aircrew or astronauts, or you could be looking at life support systems, or getting in amongst the engineers and looking at the system design and testing bits. So it's yeah, lots of different bits. Blatant self-plug here for my approach to the topic and the subject in this overview of space medicine article. So underneath the broader headings of the clinical, the human performance, and human factors engineering, you've got to think about the scenario specific considerations for the individual and all the interactions that can occur between them and their protective systems, the vehicle and the environment outside. And as with aviation or space, some of the training environments can be just as hazardous or more hazardous than the operational setting as well. This is just following that slightly further in terms of how I approach the topic and leading on to how we do some of our research, but thinking about the physics of the environmental exposures, what the physiological or pathophysiological and performance effects of those exposures might be, and then what we might need to do in terms of protection or intervention and mitigations for people in these hazardous environments. And we are aiming to help them survive, function and perform, and the way that we can do that with research to help out is potentially to identify the hazards or the effects, understand them, and then potentially mitigate them through the protection measures. Ross has already talked about this variety of areas that we might do research on those bits, so I won't go over those anymore, other than to illuminate that I know there are some engineers within the group, and so one of my personal interests is this interplay between the physiology and medicine and the engineering. Again, coming back to the importance of different culture and language, but also diversity of views to try and get better solutions in these different settings. In the interest of time, I won't spend too long on these, but I just want to illuminate some of the different ways in which the research can get involved in this interplay with the engineering. So in the design and specification type cycle, we might get involved as physiologists or aerospace medicine doctors in any of the test elements, from the early specification bits through to the lab testing. And here are just a few examples in a thermal chamber, simulator, altitude chamber, centrifuge. And this is the old one that me and Ross know well. I still miss it, but it doesn't look as shiny and new as the new RAF one up at Cranwell. But there are many different types of testing that you could get involved in, depending on what your role is within the system or what's required for that particular test bit. And as Ross has already said, one of the great bits is you can do some in-flight testing as well, potentially if needs be. So that's just an overview. These are continual cycles, and I'm a strong advocate that there should be more physiology and medicine involvement within these, and not just leaving it to the engineers. I do think these things are all team sports. And these are the kind of things that Ross has already gone through in terms of the systems that you might test. One of the recent issues in aerospace medicine on the aviation side has been unexplained, or so-called unexplained physiological events, where the pilots develop a bunch of symptoms in flight and they don't necessarily know what it's due to. And this slide just shows the challenge of interpretation, some of these clinical symptoms, because they overlap so much. And so this is driving a great interest in physiological monitoring or wearable technology, which is just a slide here to give you an indication of some of the future directions of our research, or things that we might get involved in. This is from the British Aerospace UK Team Tempest Future Fast Jet concept. And there's lots of great physiology, psychology, blurs with the engineering bits that we could get into in there, that we're active in a few areas related to this. Ross has already talked about the importance of the research in relation to suborbital spaceflight, and another area we're active in. More generally, there's lots of space stuff you could do, which you probably will get better opportunity in America to get involved in. But it is a very exciting time to try and be involved with space medicine and space exploration, and the associated research to go with that, as we're being led by America back to the moon and Gateway, and then maybe onto Mars. So over the next decade or two should be some really exciting times, and lots of opportunities for you to get involved in. Right, that's probably enough from me as well.
All right, yeah, that was another very great presentation, actually. It was good to get detail on the program and what the aims are, what the future of the field is, and not just get an isolated view of how the program works from an administrative standpoint. So thank you for that. It was very, I was going to say enlightening, but it was very informative. There you go. So we do have just a few questions, not too many. So I can go ahead and start. So the first one is, you kind of touched on this, but as a program, where do you see the future goals being, or possible areas for growth? So I know programs aren't generally very static in their nature. There's always something that they're trying to achieve in new ways. So for this program, what are your future goals?
Well, at the moment, we're actually going through a process of evolving the program anyway. Aviation medicine in the US and in the UK has a tendency not to change a lot over the years. That means people don't update things. So when Pete and I started, this course had been running pretty much the same way for 10 or 15 years. So we really are going through it now and making sure it's updated to reflect the most current and up-to-date information. One of the areas that Pete and I have been talking about and making sure we're going to expand on is the space physiology side of things. We do cover it, but we do need more of that, because that is going to be quite a growing component of it going forward. And it's just making sure that we're getting the right education from that, the right experiences for people, and continuing to push that on the way that it needs to be, while still doing everything else the justice that it needs from the AvMed side of things as well. Anything you want to add to that, Pete?
Yeah, I think reflecting changes more broadly in the world and society. So we're evolving the technical content, but also the broader elements of it. So I would say historically there's been an underrepresentation of female considerations in aerospace. So we bulked up the lecture content in that, and we're also trying to grow the research area, because we think it's really important to have evidence-based practice, but also evidence-based teaching. So as we grow the research team, it's trying to develop it in areas where we think the education needs further support as well. So we've got a RAF-funded visiting fellow who's doing a broad review on potential barriers to women in aerospace in general, but also from an aerospace medicine perspective. And we ran a Royal Aeronautical Society symposium before Christmas on the topic of women in aerospace medicine. So we're trying to address some of the historic inequalities or inadequacies. Probably I would say that's an area for growth. It has come from a military fast jet focus as a course, and the civil component has grown. I suspect there's probably more growth to come on the civil commercial airline aspect and passenger fitness to fly. If you look at the kind of trend of passenger numbers pre-COVID, I think clearly there'll be a hit, and then we'll return back to that rising trajectory. So I think there'll be a growth of importance on the commercial side, and that'll be reflected in the course content. Personal interest, but also I think in the world we're going to see more space, so commercialization of space and just growth of general space activities over the next decade or two, which we'll see reflected in growth in that area of the course. What else? Bringing more people in, broadening, so it's not the program specific, but trying to broaden awareness, opportunity and access to the specialty within other medical schools. So we've got a program or a project where we're trying to understand or get a baseline of what do people know about in med school in general about aviation medicine or space medicine. More aviation, but every doctor will see patients who fly. None of them have had any education about it. So that's hopefully an area we'll see grow on the research side, on the clinical fitness to fly considerations, and then some of that will feed back into the program as well. And again, I'll just keep waffling on. Parachuting, we know very little about physiology of parachuting. So one of my personal research themes, and one of the bits that we're building into the course a bit more, are some of these slightly niche or areas in aerospace that have had less focus on the course. So they've looked more naturally at the mainstream stuff, but there's also a lot of the smaller bits. So we've got a paragliding element that we'll build in probably next year. So you're then combining kind of the cold and prolonged exposures for hypoxia, as well as the acute exposures within parachuting. And a personal interest is also the slight, going back to the hypoxia elements. You've traditionally broken down acute hypoxia in the aviation setting from the chronic mountain hypoxia, but actually with prolonged flights, the impact on fatigue, jet lag, acute mountain sickness, overlap of symptoms, actually long haul flights, there's a bit of a mix over there. So we've built in some of those bits into the course, but they're probably more subtle rather than big major growth areas. Yeah, that's probably enough on that.
Very cool. Thank you. What is the next question that we were asked? Vish, I think it's yours, yes?
Yeah. So the both of you talked a lot in your backgrounds about, all the amazing stuff you guys have achieved so far. But just like looking forward, is there anything else that either of you hope to achieve, any goals you've set for yourself in terms of what you want to achieve in your career and stuff?
I'm a simple man. No, it's more just being able to expand on what we've been doing here, and it's the reason I got into this work or any of doing research. I like doing human research. I like the poking and prodding and finding things out about people. So it's actually really just growing that the aerospace medicine side of research here within King's. Before Pete and I started, there was really only one person trying to do it. We didn't have a core of people, but now we actually do, so we can really drive it forward and actually improve that and just go out and do more. So for me, that's where it is. It's just to go out there and actually just get more research done. AvMed, space medicine, there's a chronic lack of research. So much of it was held within the military domain and things that you can't ever access and never find out about. Actually go and do the research properly and actually get it out there for the wider public consumption to see, I think is something I'd be very keen on trying to do.
Yeah, absolutely echo that. And that was a draw of coming to King's, was the team that they were growing with Ross and Tom. So we've actually got a kind of critical mass of youthful, enthusiastic people that want to try and grow it and deliver on the research side. I've probably alluded to the bits I'd be interested in, so trying to get a stream of parachute related physiology, but also wearable tech. That I think over the next decade, physiological monitoring, it's got applications from extreme environment, physiological monitoring or medical support, through military operational, aerospace, in spacesuits or in cockpits, to clinical applications. So the wearable technology will probably become the norm in clinical hospital practice, but also outpatient settings or remote telemedicine healthcare support. And some of that's been accelerated in COVID as well, as they try to think of innovative ways to do the clinical assessments without having the face-to-face contact. So I think that, and again, that link between the engineering and the physiology medicine would be a future direction. Yeah, keeping employed in these uncertain times is probably also a difficult thing. And yeah, I would hope we would have a bigger group and successful research group doing physiology or medical research to support suborbital spaceflight and the human exploration of space. So I would really like over the next 5 to 10 years to effectively set up a spacesuit lab for interdisciplinary research, but coming from our core of what's the physiology, how does that then inform the system specification, design requirements, etc. So that would be my ambition over the next 5 or 10 years at King's.
Great, thank you.
And then we were also, I'm sorry, can you hear me?
Yep.
Okay. We were also curious, just related to your background, how you think that, just a little more detail about how you think conditions in space have an adverse effect on our bodies. You could go into a little more detail.
Hours worth of lectures on this in the course. Yeah. Space is bad for you. From a physiological perspective. What's the best way to elaborate on that, Pete?
So I think that the human body is amazingly adaptive. And it will adapt to whatever environment it's put into. Sometimes those adaptations are beneficial, and sometimes they're kind of maladaptive or come with associated medical concerns. And we don't understand all of them. We probably don't know about all of them either. So again, it's one of the reasons that's interest in the field, the kind of musculoskeletal deconditioning effects or potential cardiac deconditioning that you get in space flight. In space itself, maybe doesn't matter so much. It's when you return back to a gravity environment. And that's been the traditional view, although even that's now starting to change a little bit, as some of the more recent cardiovascular studies are looking at whether space itself is directly threatening to your cardiovascular health, either from a radiation perspective or changes in the cardiac anatomy that might make you at greater risk of sort of atrial fibrillation, and how's that changing the electrical conductance patterns as well, which we probably didn't think was such an issue 5 or 10 years ago. So the deconditioning in space on those aspects was probably an acceptable adaptation while you're in space, but it's maladaptive when you're trying to come back to Earth's gravity or Martian gravity. By contrast, the stuff we've then discovered in the last 10 or 15 years, like SANS and the space-associated neuroocular syndrome, we still don't know quite why it's happening or whether it can be stopped. Does it, and in some people, does it recover fully? Or if you're on a mission to Mars, will it continue to change for the people that are susceptible to it throughout the mission? And then most recently, the idea of venous stasis and that contribution to thrombosis and the finding of the jugular vein thrombosis in the astronaut was potentially very alarming finding, and something that hadn't been previously identified as a medical hazard. And that certainly wouldn't be a positive adaptation to the spaceflight environment. And then bits that we might not be able, or probably aren't able to adapt to, would be the sort of radiation threat that we're largely protected from in the kind of space flights that we've done. Clearly, they have a greater exposure than we would on the surface, even in the low Earth orbit. But as we go beyond the protection of the magnetosphere and well outside of the atmosphere, we don't really know what that means. I don't think. You can do Earth-based radiation studies and see what the effects of exposures have been, but it's not quite the same radiation, so we still don't quite know what that will mean in space flight, and those bits I think will be more about trying to protect them from the exposure, or just accepting the risk and the uncertainty with it.
that's Pete's covered a lot of the kind of direct and obvious things that go wrong, but it's something that's going to be more and more prevalent, and it's not an area Pete and I initially experts in. It's the psychological side of things as well, particularly when we're starting looking at missions to Mars, for example. That's a very long period of time to be in a small confined environment with a few people. It's a big area that we really need to figure out and work on, and certainly there has been research done here. I mean, there has been some, was it Russians that had a load of people staying in a container for a very long time, and they
Yeah,
came out
they're
smiling.
good.
Although I do believe the reports that the unofficial reports afterwards were that maybe it wasn't all as nice as they led us to believe initially. So there's going to be challenges associated with that, definitely, which is going forward as well. There's nothing you can do about that. Just pick the right people to some extent and hope for the best. But
and they do a lot of training now. They've recognised, so conflict training, human factors training. So how do you recognise when you're not getting on with your teammates and then de-escalate it? So I'm involved in a project with a psychologist from University of Manchester, Nathan Smith, who's done quite a lot of research in extreme environments and related to space environment for the isolation confinement. So we're just going through a series of interviews with a mix of explorers and cosmonauts and some of the people from Mars 500 actually talking about what their coping strategies were and how they found it and what they thought the challenges were. So we're doing kind of thematic analysis of it to try and draw together what lessons we can to develop a guidebook for ESA on some of the different strategies that they might employ for the future missions, and to build that into some of their caves training is the intent.
Very cool.
Thank you very much. I know that was a very big question, but you answered a very wide range of stuff there. So thank you very much.
And you basically already answered the last question that we had submitted, but the question was, do you think that the effect is too negative for humans to stay in space for a prolonged period of time? So obviously the radiation plays a pivotal role in that, but I think you have these roommates in a confined space, and speaking from my very limited experience of living in a dorm, I don't think I could do it. So
it's hard, yeah. I mean, the long-term stuff, obviously you stay on the ISS for 6 months to a year. Going to Mars, it's a very long time away. The real challenges for that, you'd probably survive in space. It's what happens when you go back onto whichever surface it is you're landing on, and that's where the challenge comes in. How do we protect people from, or how do we reduce the risk associated with that? I mean, clearly there's a lot of countermeasures people use on the ISS. There's a lot of exercise countermeasures in place anyway to at least prevent some of the physical deconditioning. There will be more coming out in that, I'm sure. Doing something, I was talking about big spinning ships, so you can try and cause some gravity in some way while they're out in these flights. That is an engineering solution, which would be great because that would overcome a lot of the problems. So there will be things like that, and because of that, people can stay there for a very long time and hopefully limit the effects. Although the problem is, what's the longest anyone's been in space at the moment? Is it 400 days or something around about that? I can't remember the number. So the real question is what happens when we go out beyond that, which will have to happen. And at the moment, we don't know.
But I also think, particularly from the psychology side of it, if you take more of a historical perspective and don't view it through the kind of current societal norms, people used to go on all sorts of voyages where they disappear for years at a time. Yeah. From the psychology challenge side of it. So I think there will be ways to work through that, and often the successful teams there came down to appropriate training and selection. It probably wasn't as well thought out or evidence-based as we'd like to think it is now, but they effectively laid the path for a lot of what we do. So you see if you get on with the people, and then you do some hazardous training with them and see when you're all stressed and frayed, whether you clash or whether you find ways to work through it and cope with it. Because the conflict is inevitable. You just want to have the kind of people who don't react in a negative way to the conflict and respond in a way to resolve it. I think so. I think those the psychology things I think are all workable as well. The physiology or the radiation threats I think need more of the engineering solution probably, as Ross had talked about there. It depends how quickly you want to go and then what kind of risk the organisation and society are willing to accept for it though.
Yeah, I think it's definitely more easy to talk about than to actually like have to fathom to deal with it. But thank you. That answered the question very well. So I appreciate it. And Gautam, I believe you had one more. Sorry, that's my cat. He barked
Yes.
in.
Yes, so the last one is not necessarily content based. It was more logistics based. So obviously we were recording this meeting, and so we were wondering how comfortable you were with where we send this recording to. So we do have a YouTube channel. We were wondering if we could put it up there, if you're okay with that, or if not, we can just distribute it internally. So it's totally up to you what you are comfortable with, and we will act accordingly.
And certainly in terms of anything I've said or done, I couldn't care less, to be very honest. Put it wherever you want. Pete, I don't know if you've got anything that's a bit more. Don't think you
No,
did, but
I don't think I talked about anything that I shouldn't talk about, and I think all the slides I used have probably got appropriate sources and copyright bits on them anyway. Yeah, I think they'd all got credits on them. Yeah, no, happy.
Yeah, great. Yeah, I noticed you put the credits for like the Virgin Galactic flights and credit Virgin Galactic. I was very impressed. But
Try to.
yes, okay, fantastic. Excellent. Thank you very much again. To the both of you, this has been very informative, and it's very exciting to see just where the field is going. And I feel like we're kind of approaching the field at the right time to, like, meet with it at a time of advancement. So great. Thank you again.
Very welcome. Hopefully see you at some aerospace medicine conferences in the future.
Yeah, so I don't believe we have any more questions, and we certainly don't want to take up any more time than you guys signed on for. But I just wanted to say on behalf of all of us present and all the members that weren't able to make it but are most likely 100% going to watch the recording because they're all very interested in it, a very profound thank you for taking the time out of your day. I know it's very hard with the time change as well, so we appreciate the accommodation. And we just gained so much knowledge that we couldn't have even dreamed of a few months ago. So truly, thank you both very much. And I'm very glad that I got to email you and get to know you virtually and meet virtually. I'm very appreciative of that. So thank you again. It was awesome.
I know it was great to speak to you. It's always nice to speak to people who are interested in the field anyway.
Thanks for reaching out.
Yes, thank you. Best of luck in all future endeavors to both of you. I'm very excited. I hope I get to hear more about all of this. And if you ever want to join our future meetings or get updates, please let us know. And I will also be emailing you a thank you again. So have a great day to the both of you. And thank you so much.
It's good to speak to you.
Bye-bye.
Bye.
Thanks.
Thank you. Bye-bye.
Thank you.